Okay, so we're going to pick up where the lecture left off the other day. Thank y'all for playing this morning. By Tuesday, at the end of class, we will have finished even the respiratory, so lymphatic will finish in a few minutes. And then we will, by the end of Tuesday, finish respiratory notes. And when you all leave Tuesday, I'm going to give you a take-home test, open book, open notes. What's the only rule? You do it yourself. Right, that's all. And so just because it's a learning experience, right? So I'm going to give that to y'all so that on Thursday, you know, you don't have to come in next week on Thursday, but maybe you could use that time Thursday morning, since y'all have set these mornings aside, to do that open book, open notes test for me, because it will be due to be handed in at 9 o'clock the next time we meet on that next Tuesday, okay? So it's going to be due. What'd you say?
When we come back on Tuesday,
yeah.
we'll go over it.
Yes, and we'll go over it. And we'll go over it, absolutely. So, because I really feel like feedback is a learning tool. That's what these tests are about, feedback. Now, at the beginning of Tuesday, everybody hear this, okay? It's on recording too from a couple people who are out. At the beginning of Tuesday's class, what will we have? Major arteries, major veins, lab quiz. There will not be a lecture quiz. So that'll be a day there's no lecture quiz. So, but is everyone going to be ready for that lab? Major arteries and major veins. Good. So you guys know kind of what's going to happen next week. You're going to have a lab quiz at 9 o'clock on Tuesday morning. At the end of that day, I'm going to give you your take-home lymphatic respiratory test, and that's going to be due back at the beginning of class on the Tuesday we come back. But fair enough? Tentatively, schedule-wise, I want you all to know that week, that we come back after next week. We're going to, that week, be doing the urinary and digestive systems. There are really 4 chapters associated with the urinary and digestive systems, and a couple of labs, actually. So we are going to do that week. And then the final week in this class is reproduction, which is male and female reproduction. Chapter 29 is actually a little bit of a review of maybe the whole A&P. It's about senescence and aging, and embryology a little bit. So there's a little bit in 29 that we do, but not much. The last, actually, it's really going to be the first day of exams. You all will have 2 tests in here. There will be the final test on reproduction. We'll go over that together. You all can take as long a break as you want, and then you'll have to come back in here and do the final exam. Does everybody know what the final exam is going to be on?
Is it 30th?
Yes. Yeah.
Yeah. 30th is our last week?
Yes. It'll be, is that 30th of Tuesday? Yes. Yeah. So I think it's either the 30th or we're going to do that on the 2nd. The 2nd, actually. Let me say that. It's going to be the 2nd, not the 30th.
It's the 2nd to that Thursday?
Yes.
That's the final.
That's the final test on reproduction, and it's going to be the final exam the same day. So we're going to all take that reproduction test, all go over it, know what you missed, if you missed something, if it was related to a hormone or a disorder. Are you going to know it before you come back and take the final exam? And you can take a break. Some of you will want just go ahead and take the final exam right then. That'll be fine. But you'll have plenty of time to study in between if you want to. Okay? All right, so y'all kind of tentatively know what's going to happen the last couple weeks in here. This is a condensed class. 8 weeks y'all are doing this. You have got to be time managing and knowing, okay? And I know that's a tough way to do it. But you got to be on top of it. Yes, Jada.
I know you said it's hormones, but there's no disorders or...
Oh, yeah, they are. It's going to be disorders, coincides with hormones, but it's heavy in hormones. It is. I'm just going to let you know. It's heavy in hormones and disorders. Yeah.
For the Thursday that we're going to be in the too. Like,
yes, you would have a reproductive male. Well, I don't know. You may have tried to be able to do them before then, but you might have to label male and female. It's whatever. Our lab's pretty. Except for when maybe you weren't expecting them. Our lab's pretty easy, really, labeling, right? Because I do give you all the exact structures you're supposed to be able to label. So the labs shouldn't be, the labeling shouldn't be taking up too much of your time. But yeah, usually the last day, almost always, even if it's a 16-week course, usually the last day, the people are taking Maya and Brianna. You might be disturbed with people in front of you. I mean, you might don't apologize to them. But the last day is usually the final test on what we have covered. You go over it. There's usually a final lab that day. You know, you do the lab before you do the final test, just like y'all did today. Y'all should be kind of used to me by now. And then y'all can take a break. And I use this room as our exam room that day. And you can just come in when you're ready to take the final exam. So you could go to the library and study 2 hours if you wanted to before you come back in here. Or you could take it right away. I'll be in here waiting for you. There will be a final time that you need to start it by, right? So that's kind of how it's going to work. The main thing for you all, and don't think I don't empathize with your schedules. I am humbled by your schedules and what y'all are doing. But please, please be practical about your time management and how much time you're putting in to be able to review for this stuff. Okay? Yes.
How soon after the semester ends do you have to have grades in?
I'll have them that day.
Okay.
You'll know
So
your
the
grade
second-
that day.
But when is it required? Because I have another class that
Oh, so you worry about somebody else, not me. Because you know
I know you're on point.
I was going to say I can y'all get back all the time.
Okay.
So your grades will be in for me that day, but grades don't have to be in until like May the 8th or 9th or something. I think it's May 8th or 9th.
We worry about others. They wait to see.
They will.
Yeah,
They're going
she
to wait.
said that May.
They won't. Yeah.
She said May was when they were going to send out letters, but I was like, okay, well, how early
Oh, I
in May?
can
That's
promise
where
you
I
that some
was.
people will wait till the last minute, but they have to.
Okay.
They're going to give time. Okay, guys. So y'all, any other questions? Those are good questions. Those are good questions. Really good. So, are we ready? You ready? All right. All right. So here we go. We had stopped with natural, active, and passive immunity, right? I will ask you questions about tell me which is which. So if you're if you're a baby getting breast milk, what kind of immunity is that? It's natural passive, isn't it? If you've been exposed to something and they give you immunoglobulin, they're giving you the antibodies in a shot. What is that called? Artificial passive, isn't it? If you've gotten the disease, so you went through a time of illness, you went through the prodromal, the active stage of illness, and the convalescence, and made your own antibodies. What is that? That's natural active, isn't it? If you got an immunization, what is that? Artificial active. Are you good with that? So y'all know those, and you know how they can protect you. Now, I want you all to listen to me because, I feel like I try really hard to break this down for you and put it in kind of common language and language that can help you to understand it. Reading a textbook's important and it's good, and you need to kind of get used to reading that kind of language because NCLEX questions can sometimes look like that. But I'm trying to break this down for you. Now, we know our immune system is amazing. It's the reason we can get out of infancy, isn't it? We're born with innate things that are non-specific but protect us, but we're also born with a specific immunity that we can respond to specific foreign pathogens and protect ourselves and have lifelong immunity. So that's an amazing thing our immune system does, and we need to keep it on point, right? But it can be too much, or it can be not enough. So we're going to look at the cases when it's too much. And these are called overreactions of the immune system or hypersensitivities, if you will. There are 4 types. I'm going to give you the basics of what those 4 types are of the overreaction. The first type, type 1, had I already done this? No. Okay, the type 1 is, I just did it in micro, so there's a little bit of over repeat here, so we're getting who I talked to. So anyway, the first type, type 1, is going to be an immediate reaction. These are immediate reactions, usually IgE antibodies are involved, IgE. And y'all told me that those are going to respond to allergies and parasites, didn't you? Did y'all tell me that? Y'all knew that, right? Or maybe you hadn't studied it, but it's in your notes. IgE. So this is what you all think of as like hay fever, pollen reactions, asthma. Asthma, can you have an immediate reaction where your airways close? Y'all need to know asthma is reactive airway disease due to allergens. An allergen is anything that can elicit an overimmune response, anything. So, so do you get that? So type 1 is all about that immediate hyper response, and the major worry of that is the closing of airways, isn't it? Because what can it put you into?
Shock.
Anaphylactic shock. And I need y'all to know that anaphylactic shock is when these airways close down enough that you're not getting enough air. Can it be life-threatening? Yes. So what do we know we can give that will relax airways? Epinephrine, the EpiPens, exactly. But what do we know they're going to be doing to your cardiovascular system? Jacking it, aren't they? Is that right? So we're going to have to worry about that then. But this is type 1, okay? Now type 2, that what I would, type 2, 3, and 4 can actually be so much of a response, those 3, that they can lead to autoimmune diseases. And what's an autoimmune disease? It's your immune system attacking your own cells. That's not a good thing, is it? Is it? Can you catch? Is it a communicable thing? Is it contagious? No, it's your own immune system attacking yourself. So in type 2, 3, and 4, this is where we get again to see those autoimmune diseases that we've been talking about. But type 2 is typically going to be because of an antibody reactions with your cells, and this is going to be the problem. So an example could be like transfusion reactions, right? The RODAM thing we talked about. Remember RODAM and erythroblastosis fetalis, right? Type 3 is again about antibodies, but it's antibodies forming these complexes in your own tissues, in your own tissue membranes. So this can end up attacking whole organs. Does that even sound like that would be a good thing? Does it? No, it doesn't, does it? So this is something we don't like to see either. Is this type 3 because this is where we looked at acute glomerulonephritis. Well, have we looked at that yet? No. Okay. Well, I'm gonna tell you now. Okay, sorry. All right. So y'all just listen to me a second. When y'all get strep throat, this is a sore throat pharyngitis caused from a bacterium known as Streptococcus pyogenes, right? And many of you had strep throat. And what did they put you on? Why did they put you on? To do what? Oh, really? Why'd you get on an antibiotic?
To kill the bacteria that cause it.
To treat the bacterium that causes it. That's one reason. That's actually one of the minor reasons. But that is one reason. But what's the major reason? One, because your throat was sore. Nobody cared. You were not going to die from the sore throat. No, it wasn't even that. Nobody cared about that either. You were not going to die from that. You were going to get over it eventually.
Bacteria.
Because people, what we know, in rare cases, rare, but it's the reason we treat everybody who has a strep throat to prevent this rare occurrence. What we know is that rarely, it's rare, but it can actually cause an overimmune response that will actually form these complexes of antibodies in the tissues and shut your kidneys down. That's called acute, it happens quickly, glomerulonephritis. It usually happens around the 6th or 7th day. So if we can do something to suppress your immune response, guess what antibiotics do? Yes, Nicole, they do treat the bacterium, but that bacterium was never going to go to your kidneys. But guess what antibiotics also do? They suppress your own immune response. So they're giving you the antibiotics to actually suppress your immune response so that you won't develop acute glomerulonephritis. Do you get what I'm saying? Same thing with really rheumatic fever, which is going to attack the valves of the heart. So when you're getting treated for strep throat, it's not because we care about your sore throat. I mean, your mama cares, but medical people don't care. You're treating them so that it can prevent these rare cases of where kidneys are destroyed. Fair enough? And why are the kidneys being destroyed? Because of the bacterium? No, because of the overimmune response. And antibiotics will suppress the immune response. This is why you don't want to take antibiotics unless it's for a very real reason. Because if you take them, are you suppressing that person's own immune system?
Yes.
Yes. So you should be judicious in how you hand out antibiotics for many reasons, but that's one of them. All right, lupus is another one. Y'all know people with lupus that have systemic lupus. It's not just attacking one area, is it? It's attacking skin, joints. It can do muscles, connective tissues in the viscera. It can be pretty serious. There's different types of lupus, but the systemic lupus is a serious autoimmune disease. So what do we have to do when we treat people that have these hyper reactions? We have to suppress their immune response, don't we? That's how you treat these, is suppressing their immune response. Is there a side effect of suppressing somebody's immune response? Yes. Because what could happen? Yes, you suppress it so much that then they get an opportunistic disease that takes them out of the world. So you have to know what you're doing. Yeah, and it's a catch-22, but you have to do it. Type 4 is a delayed reaction. So you guys have all heard of like poison ivy. Do you break out with poison ivy as soon as you were like doing something in the woods? No, you don't. It's later, isn't it? So there's something called pactins that are involved in this type of delayed hypersensitivity. Pactins, and these are small molecules that have to work with molecules in the person's body that are going to then elicit an immune response. Do you get what I mean? And sometimes you can develop these. So just because you didn't ever break out in poison ivy or oak or whatever you were playing in when you were little, doesn't mean that you're not going to next week. Do you know what I mean? So you can develop these delayed hypersensitivity reactions. It seems like there's even now in type 1, which we said are immediate, right? Did we say that about type 1 are immediate? Yes. Where's type 1? Right there. It seems like now we have a lot of adults being diagnosed with adult onset asthma. Have y'all heard of that? We have a ton of adults now. What do you think that's contributing to that? Because we said this is going to be because of allergens causing reactions, the body overreacting and hyper-secreting these histamines that end up causing these symptoms. But why do you think we're seeing adults developing asthma as adults? Why do you think? They're developing allergies, but why do you think we're seeing almost, like it's considered to be almost in epidemic proportions that we've got adults now developing adult onset asthma?
Allergens are starting to.
Yeah, so like polluted. I didn't hear everybody's response, but I'm sure they were all legitimate and had validity. It's because we're in environments now that are very different. It's not like we get born into a little enclave of society and work on our farm and die on our farm now, is it? Now people are actually going a lot of places where things are new, right, to them, but there's also much more pollution. And so it's the environment. It's the environment that's pushing that. And so anytime you go into a new area, does your body's immune system have to be able to adjust to it, doesn't it? And so sometimes people now are actually building these. So it plays a role. And I mean, we know it's playing a role. There wasn't an answer to that question. But that's what we think is happening. You know what I'm saying? That's what we think is happening. And then we've got all kinds of packaging and stuff. Y'all know that, y'all have all heard that even new car smells and stuff. Is that stuff healthy? Like carpeting and all that stuff. Is that stuff healthy to be breathing in? No. So it's all kinds of things probably contributing to it. So those are when the immune system is actually overbuilt. doing, right? And we said that the failure of self-tolerance means that you're going to produce these autoantibodies. Auto means self, doesn't it? So now you're making these antibodies against your own tissues. Type 1 diabetes, wasn't that an example of that? How about my thyroid disease, Hashimoto's thyroiditis, right? Right? The 1 in 8 women over 30 had that. So these are when you're making your own antibodies against your own cells. Now that's an overreaction, but then you can also have a deficiency. I want you all to know about 2 types of deficiency. One is called primary, and one is called secondary, okay? Primary immunodeficiencies mean that you're born with them. And maybe that would make sense to you. You're born with them. So you're born with a genetic lack. You didn't get the recipes to make some of your complement proteins. You remember complement proteins? You didn't get the recipe to make some of those classes of those antibodies that, you know, we talked about, those gamma globulins, those immune globulins that protect you. You are lacking something of those. Hey, you might be born lacking a thymus. What do we know the thymus? Well, you're not really lacking thymus, but you're lacking the sensitivity to the thymuses and or the production of thymuses. And if you don't have thymuses, what can't mature? T lymphocytes. And wait a minute, do you know anything about T lymphocytes? How many T lymphocytes do you know? Andrea's like, stop looking at me. How many T lymphocytes do you know? 4. You know the CD4 T lymphocytes, right? Helper Ts. You know the CD8 cytotoxic Ts, don't you? Yes. You know the suppressor T lymphocytes, don't you? And then there are actually some other classes like, you know, natural killer cell T lymphocytes too. So guys, we understand that you can't survive without that. If you're born with SCIDS, severe combined immune deficiency syndrome, you're in a bubble. You're put in a bubble, and you're never going to be able to touch human skin. You're never going to be able to eat or drink food regularly. It's going to have to be sterilized. In other words, before modern medicine, did you die in infancy? Did you die in infancy? You did. Now with modern medicine, they're put in a bubble, and usually they try to do stem cell replacement to try to get their immune system boosted enough that they can come out of the bubble. But will they always be immunocompromised? And will maybe even a very, what we consider to be a very non-dangerous virus take them out? Yes. Yes. So there's all different types of primary immunodeficiency, things that you might be born with that is making you a little bit more susceptible to disease than other people would be. The key about that is finding out exactly what it is and, you know, getting the proper therapy. Now, you can also have a secondary immunodeficiency. A secondary one is the one that you acquire. You acquire. If you are, let me tell you what a secondary, this is maybe stretching a little bit, but not really. If somebody has influenza, why do we want people to get immunized against the flu? Well, to prevent the spread, it's absolutely true, but mostly because to prevent the spread to people who are already immunocompromised. They're either really young, or they're really old, or they have really old, or they had cancer, or they, you know, have something that's already made them a little bit weak. So you don't want them getting it because they got a much higher chance of doing what? Dying from it. Is that right? But even people that get influenza that are young, healthy, in their prime, like y'all, once you've had that, are you at risk for something coming on top of it? Yes. You kind of are, right? You are. The secondary immunodeficiencies are because you have something that's making your immune system now weak. The one we always think of as a secondary immunodeficiency that's acquired is from HIV, right? HIV stands for human immunodeficiency virus, and it causes AIDS. It can lead to, not always if it's treated, it can lead to AIDS, acquired immune deficiency syndrome. Have I talked to you about whether HIV is easily transmitted or not? Yeah, so we talked about all of that. Then we know exactly what it stands for. We know how it's transmitted, and knowing all of that, knowing the epidemiology, the study of what causes it, how it's transmitted, how long its signs and symptoms going to be, and the whole progression of the disease, how it's to be treated. knowing that helps us to what? Be able to also control it, right? And maybe through education or whatever, trying to limit the spread of it and that sort of thing. So great. Now, treatments are going to be, treatments are ongoing as far as like study of the treatments, but the treatments are going to be vital to the survival of people who are HIV positive status. And now with proper treatment and proper management, people can, sometimes hope for a normal lifespan. Before it was going to be greatly shortened, right? But now normal lifespans. How do y'all feel about your immune system? Students have heard about hormones, the endocrine. They know about cardiovascular. This lymphatic system, this immunology, the study of the immune system, is usually the most foreign information to students. But still, students tend to get this a little bit easier than they get the other two. Y'all feel okay about it? Okay, just because it's open book, open notes doesn't mean that it's memorization, right? You need to own it. So as you've gotten good notes, they should help you to be able to go through your little test pretty easily. Like, couldn't y'all have taken this test that you just took on cardiovascular system? Couldn't you have taken it pretty easily if I told you, okay, everybody open your notes, right? So if you're taking good notes if you took good notes on this, that take-home test shouldn't be bad, but please do study it, even though. And same thing with respiratory. We're about to start with respiratory, okay? All right. Do I have any questions before I begin this one?
For the acute, I can't say the G word.
Gamma globulin?
Yes.
Okay.
Yeah, but that's the kidneys being destroyed.
Oh, acute glomerulonephritis.
Yes.
Okay, all right, guys. So, okay, all right. So, sorry. Acute means what? It means the signs and symptoms come on kind of suddenly, and they're usually pretty serious. All right, so let me tell you what glomerulonephritis means, because y'all should always tell me, wait a minute, that looks like a big word, but we know it's not, right? So let's break it down. The glomeruli, or glomerulus is singular, glomeruli are plural. The glomerulus is the filters in the kidneys. They're the filters that are filtering what?
The blood.
They're microscopic, and you have millions of them, but it's a finite number of them. They are literally your filters. Think about your coffee filter. Does everybody have coffee filters at home? I wish I had some coffee. So coffee filter. They're your little filters in your kidneys, millions of them. But a finite number, meaning that they're precious. I love that word, precious. Okay. Nephron is the functioning units of the kidneys. That includes the glomerulus and then all the ducts that are necessary for the filtrate to move through the kidneys. So nephrons are the functioning units of the kidneys. What's the filter? Glomerulus, right? Plural is glomeruli. So now when I say that someone can have, because of their immune response, it's their own immune response to streptococcus. There's antibodies will lay down in those glomeruli. It's going to cause inflammation of those functioning units of the kidneys. Do y'all get it? And let me tell you what it's going to do. It's going to shut their kidneys down. The pee that they are peeing, the urine that they are peeing is black. Should it be? No. Blood is coming through and it's thick and nothing is filtering. It's their blood. Their kidneys are shutting down and it's happening quickly. The last case I worked on at UVA was a little boy who lost both his kidneys. He lost both his kidneys and had to go on a kidney transplant. He went on full-time dialysis until he went on a kidney transplant. Yes.
Would you say
The filters in the kidneys. What are the nephrons? Functioning units, the whole unit. Right? What is itis? Inflammation of those. Right? Now, just because someone is starting to go into acute glomerulonephritis, if you can stop it, and again, guess how you have to try to stop it? Suppressing that immune response, giving a break to the kidneys by putting them on full-time dialysis, so the kidneys can get a break, and you can try to control that inflammation and hopefully save some of the kidneys. Now, if we could have saved some of his kidneys, then he wouldn't have had to go on the transplant list, but his kidneys were done. Really before he even got us.
So that is the rare occurrence. That's what.
That's a rare occurrence, but it's why everyone gets treated. A less rare occurrence is rheumatic fever, where the valves in the heart are going to be affected. If people have mitral valve prolapse, do y'all know what mitral valve prolapse means? What valve is it? Where is it, I should say. Ashley. Ashley, oh, you can. Where is that mitral valve? Where's mitral valve? It's between the left atrium and the left ventricle, right? And we understand which side of the heart, the left or the right, really has a tremendous amount of pressure associated with it. The left. So when that left ventricle is pumping blood through, think about that, left ventricle pumping blood throughout your body. You know, think about that. That's quite a bit of pressure, isn't it? And we want the blood going one direction, but you understand that it's also putting pressure on that mitral valve, right? If that mitral valve prolapses, it means blood will be going in the backward direction, which is putting more strain on the heart. So we don't want mitral valve prolapse. Now, some people have it and they can kind of live with it depending on the degree of it. But some people can't. And then what's going to happen? To replace the valve. Surgery to replace the valve. Did I tell y'all they just started doing that whole valve replacement through, which is really awesome. They don't have to do, well, they're still mostly doing open heart surgery for that, but maybe soon they won't have to. Right? All right. So good. Great. All right, y'all good? Good questions. All right. So let's see the respiratory system. So why are you breathing? When we think about a ventilation rate, what do we mean by ventilation rates? Tell me and explain it. What does it mean? A ventilation rate. What is a normal ventilation rate for an adult at rest? Yeah, so they can't say even 12 to 20, you'll see sometimes, but yeah, we usually see it around 16, to be honest with you. And that's, what does it mean though? So it's 16 what? Breaths in and out. So a ventilation rate includes one inspiration and one expiration. That's a ventilation rate. That's a ventilation. And then you're going to have, you know, it can, for a normal adult at rest, it can be from 12 to 20. So Nicole, is your ventilation rate that you had when you sat down here this morning the same as it is right now, do you think? If I measured it, it could have maybe been at like 18, but now it might be at 12. What makes it change? Why are you breathing at the rate you're breathing? Are you having to think about breathing? Whenever you have to think about breathing, don't you feel breathless? And this is why when you're doing vital signs on patients, you don't tell them you're measuring it, do you? You don't let them know you're measuring it because they're going to start doing like weird stuff. You know, I don't know what, panning, they're going to start doing. That's what I do. I even do that. When they say, I even do it and I know that I should do it. But they'll say like, okay, take a deep breath and hold it. Okay, I think I forgot how to do that. I'm like, wait, what? So anyway, you don't tell patients you're doing that because it makes them breathless. But you're measuring how many times they're breathing in and out in a minute, right? And it doesn't stay the same. What's influencing it? What is, well, I know, but I mean, your activity obviously would, but why are you breathing at the rate you're breathing? What's controlling it? You're not having to think about it. What? Your autonomic nervous system, you're absolutely true. It's the autonomic nervous system. It's really the medulla and the pons. But that's the area that the signals are coming from. But why are they sending the signals they're sending to you to breathe in and out? What is driving it? No, but I mean, what level is driving it? Your pH. I'm obviously not asking the question right. You said pH.
I said pH. We talked about it before.
We talked about it before and you remembered it. Most people, thank you for remembering it. Most people say because you need oxygen for what? To live. But for what? Y'all know more than to live. For what kind of respiration? Cellular respiration, also called what? Aerobic respiration. You need oxygen. You guys don't forget that we're just little chemistry things walking around, right? And y'all remember that aerobic respiration was C6H12O6 plus what? 6 what? O2. 6O2. 6O2. And what is O2?
Oxygen.
And if you had those two, then you would give off as waste products what?
CO2.
And it's 6 of each of these. 6 CO2 and 6 what? Do y'all remember that? Okay. Let's remember no phones. All right. So you got to have oxygen. But we said this equation is nerdy. We don't care too much about that. What we cared about was what was happening in the story. Is that right? And what do we know we really need these for? Inside of our cells, what do we need them for? ATP. To make ATP, which is our molecule that is our charged battery, right? So if we don't get charged batteries, how much can we do? Nothing. Like honestly, you know how your phone will turn off? Well, guess what's the first tissue that's affected by batteries being low in a body? The nervous system. Guess what system is controlling all homeostasis? The nervous system. We just saw how the nervous system sends signals to the endocrine glands to produce these amazing hormones. Do y'all think that takes work? Do you think it takes work for the nervous system? The nervous system is the most at risk when there's not charged batteries. What charges our batteries? ATP being there is a charged battery. But what gives us ATP? Cellular aerobic respiration. And what is one of the reactants we've got to have for that? Oxygen. So let me tell you, that's not the main reason you're breathing. That's what most people think, you know. But that is. And let me say this to you, because I think Andrea won't care if I touch it. Look, guys, it's not oxygen isn't the main driving force for her right now because she's healthy. She's healthy and she's not underwater. But if she were underwater, or if somebody close, if somebody close to nose and mouth, would oxygen then take over and become the main stimulus? Yes. You know, if you've ever been choking, guess what? That's a panicky moment, isn't it? I just read an obituary this morning. You know, when you're old, you'll know when you're old when you start reading the what? I do it all the time. I've been reading for years. Okay, so anyway, I saw this young guy. He's in his 40s. It's a 9 and a 10-year-old. It broke my heart. He died from choking in a restaurant on vacation. And I was reading that thinking, oh my God, how awful is that, right? We have to have oxygen. Now, but usually we do have oxygen because we are fortunate enough that we have this atmosphere that has oxygen in it. So unless something is keeping you from breathing, like choking, or somebody covering, smothering, or being underwater, that's not going to be. You're going to get oxygen just as an aside. The major stimulus for you breathing is to control the pH of your cerebrospinal fluid. That's the major stimulus for you to be breathing. Your pons and medulla, your central nervous system is monitoring the pH of your CSF. And if your pH, depending on what it is, your respirations are going to increase or decrease to keep your pH balanced. Are you with me? This is the hardest part, what I'm telling you right now, about learning what we need to get, and we do need to get it, in the respiratory system. So this is what I'm going to talk about here first, because the rest of it's just gravy after that. I wish I had some gravy on biscuits. Okay, look, so can I tell y'all, have you ever watched The Pimple Popper?
Yes.
All right, okay, this is just a quick, but have y'all really watched that?
Yeah.
All right, if you haven't watched that, if you have not watched that, it is exactly what it says. It's like they're removing lipomas and some cysts, and it's really like I had to stop watching it though, because I have watched a couple of them, and everything she talks about, she relates what she's doing to what. She has ruined so much food for me. I was like, okay, I'm gonna stop watching this because I don't like the way she talks. She describes everything she is extracting. She describes it as food, and I thought, what? Stop doing that. All right, look. Guys, I want you to look at this equation. You know, I told you in A&P1 in the first week or so that it's rare that I would ever get you to learn an equation, a chemical equation. I got you to learn the aerobic respiration, didn't I? And this is the second one, really. Here it is. You ready? I want you to write it down first and have it in your notes because you're going to have to refer to it to answer a couple of questions on the take-home test. So there's your incentive for it, okay? Write down CO2 plus water. Then an arrow to the right, and then write down H2CO3, arrow to the right, then write down HCO3 anion, a little negative sign, plus hydrogen ion, which is a plus sign, okay? Cation, okay? So did everybody write that down? Everybody write that down. All right. Now, I want, in case you don't know, H2CO3 is carbonic acid. H2CO3 is carbonic acid. HCO3 with anion is bicarbonate. Bicarbonate. And you know, H with a little plus means it gave away its electron. So this is a hydrogen ion. Is that right? It's a hydrogen cation, positively charged, right? And do y'all know what CO2 is? What is that? And you know what H2O is? What is that? All right. Everybody got the equation written? Everybody got the equation written? Are we good? All right, Maya. Maya, have you ever seen, Maya, CO2 and water together in an equation? Have you ever seen them together in an equation before? You haven't? Really? Did you write down the aerobic respiration equation? Go back and look at your aerobic respiration equation. What are the end products of aerobic respiration? And did you write it down?
Yeah.
What are the end products? Of carbon dioxide and water. So you see them together, don't you? And as the end products of aerobic respiration. Now we're seeing those end products because they're waste products. I want y'all to think about right now the trillions of cells. And every one of them are pumping out CO2 and water. Are you going to have a way to deal with that? Why are every one of your cells pumping out CO2 and water? Why?
Because they are
You know what they say about everybody knows what you're thinking in your own little world. I feel like sometimes I have to remind, and thank y'all for reminding me that, you know, because sometimes I think okay, you ready? All right. Okay, guys. And I'm going to have to do this because I did it in MP1, but I don't think you realize that I kind of needed you to understand it because, and intuitively understand it, okay? What is this? What is this representing? A cell. It's a cell? So what is this part of the cell? Cytoplasm. What was this?
the membrane.
Membrane. This is the nuclear membrane. Is that right? And then we know we had endoplasmic reticulum, didn't we? Where proteins and lipids were being made. That sounds like it takes work, doesn't it? And then we had these little organelles. Right. And then we had this big organelle that took products that were being made and the endoplasmic reticulum. This is the Golgi apparatus, right? Packaging and shipping. Is it right? So is this familiar to everybody? All right. And we said our cells are really factories. Factories have to have the lights on. They have to be running the belts. They have to be doing, and for that they need what? Energy. And what was the molecule that we said was going to be the energy molecule? ATP. Is that right? And it sounds like we have to keep charging the batteries over and over. Because batteries become uncharged because energy was given up. And now they've got to be recharged. And there's got to be a constant way we can recharge our batteries. Is that true? Is that true? All right. So in aerobic respiration, we said as long as we have C6H12O6 and we can bring it into our cells. Now we have to have a way to bring it into our cells. We know how we bring it into our cells, what has to escort it. All right. But as long as we can bring it into our cells, we can split it. Once it gets into cells, we have these enzymes that can help to split it. And you know what we can get as a net from splitting just glucose? We can get 2 molecules of ATP. Is that good? That's really good. We would have never evolved if that was the end of that story. But we know it's not the end of the story because we know there's another reactant. What is it?
Oxygen.
6 oxygen. And if we can bring oxygen into the cell, the story is all about what's happening in this cell. You understand that? Does everybody intuitively understand that? Because if we split this glucose, if glucose gets split, and by the way, that's simply called glycolysis. What is lysis? Splitting lyse of glucose, right? So we split it. We said we got this. That's awesome. Isn't that awesome? But what we said is if we split it, there's going to be, they're called pyruvates. Y'all don't need to know that. Let's talk about nerd, okay? But there's going to be these 2 molecules called pyruvates. And guess what organelle? And if y'all don't mind, I'm going to take this organelle right here and I'm going to blow it up to just be bigger so you all can see it. Okay? Do you get what I mean? But if we have this pyruvate from splitting glucose, we can bring it into this organelle. Does anybody remember what this organelle was called? The mitochondria. Is that right? The mitochondria. What did we call the mitochondria? We called it the what is the powerhouse, because what's being made there? A lot of ATP is being made. So if we can bring the split glucose in here, we can actually get another 2 ATP net. 2 ATP. So now we got how many ATP? How many batteries did we charge? 4. We still wouldn't have evolved because we need way more than that. Way more than that. Where is this mitochondria found? These are found inside our cells, right? And this is where the oxygen plays a huge role because if this comes in, if O2 is coming in, the products that we get from this glucose going through is called the Krebs cycle. We can actually, oxygen can drive more reactions and we can get how many more ATP? We can get 32 more ATP. This was the first step. This was the second step. And this is the third step of getting ATP. So a total amount. Just by bringing in glucose and 6 oxygen, we can get how many ATP? We can get 36 of these babies right here charged, ADP to ATP charged. That sounds like a good thing, doesn't it? Now, that looks ridiculous, but were y'all following that? Yes. Okay, were you, Jada? You following that? Is anybody not following that? Did anybody zone out? Did you? Or if you did, I would really encourage you to go back and listen to this because this is important, okay? And so many things are relying on this. Now, here's the thing. With all of that's going on, with splitting, are you good, Alexa? Y'all are good? Yeah, where did the 32 come from again? The 32 ATP comes from oxygen coming in. Okay, so the first thing is glucose gets split. You get 2 ATP. Glucose gets brought into the mitochondria, and there's something called the Krebs cycle that it enters into. And from that second step Krebs cycle, how many ATP can you get? 2. And then the third step is when oxygen is coming in. And oxygen in this is called the electron phosphorylation transfer. ETP, it's referred to as. I don't care that you know that. But I just want you to know that with this third step, how many more ATP do you get? 32. So a total of how many? And that sounds wonderful, doesn't it? But anything that's wonderful is going to take, you're going to end up getting a little bit of waste. Right? So I do want you to understand the waste from this part is going to be what? And the waste from this part is going to be what? Water. Is going to be water. And there are 6 of these. And so all of our cells are pumping out what? Are pumping out what? And is that okay? That's okay that they're pumping out that. That actually is proof that our cells are what? Working and are alive. And we got to understand that we're going to be pumping that out, so are we going to have to deal with it?
Yes.
Can we deal with it?
Yes.
Now I want to go back to that other equation. You ready? I want to go back to this other equation. And I want to ask you all again something. Have you ever seen these two things together?
Yes.
You've seen them as end products of what?
Respiration.
Which is just saying that you've seen them as end products from our cells working. Our cells are constantly 24/7 putting out CO2 and water. Do you want to have a way to deal with it?
Yes.
All right. The major player to deal with it is our breathing, is our respiration. That's the major way. It's an entire organ system that's major function is to balance your pH. This is why when people have respiratory disease, they usually die from complications of pH imbalances. Are you with me? We refer to them as usually as respiratory acidosis. And that is just like a spiral that is not going to go to a good place. You get what I mean? All right, so let's see how we deal with it. Let's see how we deal with it. You ready? How our respiratory system's dealing with it. What happens in our body as CO2 and water are being created, and it takes enzymes. Didn't we say the real interesting part of a chemical reaction isn't this? It's actually what's happening here, what's happening in these arrows, right? So what happens in our body is we have these enzymes that will quickly convert this because we're making it at a pretty good clip, right? So they will quickly convert it to carbonic acid. Now look, does it even sound like it would be a good thing if it stayed as carbonic acid? Does it sound like that would be a good thing? Well, it isn't going to stay because we have also enzymes that are then going to quickly convert this to bicarbonate. Bicarbonate is no more than really like water, essentially. It is an anion, which means it has a charge. And I told you the ions, whether they're positive or negatively charged, are helping to move solutes and fluids throughout the system and keeping the electricity of your cells where they need to be, right? But you're going to get bicarbonate and you're going to get this. Now I want you to pay attention to this because what did you tell me is the definition of pH?
It's the negative log of, go ahead, Erin. I heard the concentration.
Inverse of the 10 count.
Knowing how much hydrogen ions you have in that.
What'd you say? Say it loud.
Knowing how much hydrogen ions you have.
To know pH, it means you know how many of these you have. Do you remember that? It's how many of those you have. Now, what did we say is normal pH for most body fluids? What'd you say? 7.35 to 7.45. Is that right? So your set points are usually around, set is usually around 7.4. And are you vacillating around that? So does that mean, I need to erase something. All right, does that mean that you are in any given person, you are vacillating around 7.45 to 7.35. You are vacillating around 7.4. Is that right? That means that your pH is normal for it to be going up, but then it's also going to be normal that you respond to it going too high and it bringing it back down. Is that right? Is that right?
Yes.
All right, y'all are going to have to understand this. Bill answers several questions. All right, so please stay with me. All right. Now, you told me that this is normal for your cells to be getting off as waste. And as it's building up in your system, you said this is going to build up. And if you remember from this scale, you remember 7 is normal, right? Normal pH. But the lower you go, what happened to your number of hydrogens?
The higher.
It went higher. Is that right? I can't write at the same point. But do y'all get that? So this is called normal pH, which just means that it's equal numbers of hydrogen to OH anions. And you said that if you were going this direction, what's happening to your amount of hydrogen?
Low.
It's going down. So we said actually the lower the number, the more hydrogens happening. Is right that you got? Is that right? And what did we call a low number? We said you're in what? It's acid, or you're in acidosis. And what about this? Alkalosis, or we said this is called basic, right? Base, a base has this. Okay. All right. So is that a reminder for you guys about pH? We're going to take a break in a minute. You with me? Mm-hmm. All right. So let me say this to you. The beautiful thing about your respiratory system, and it's your nervous system, your medulla and pons, measuring pH, measuring how much of this is in cerebrospinal fluid, hoping to keep it in this range, that's controlling your breathing. The slower you are breathing, see if this doesn't make sense to you. The slower you are breathing, the slower you're breathing, what's building up?
CO2.
So the slower you're breathing, what it also is building up?
Hydrogen.
And what's happening to your pH?
It's going down.
It's going down. But the faster you are breathing, you can actually turn this and push this stuff out. You can push this out. You're getting rid of hydrogen ions. So when your respirations increase, you're blowing this off, right? When they slow down, you're building it up. Does that make sense? The toughest part about visualizing this is that this scale is written as a what?
Inverse.
It's written inversely. So you have to really understand this equation to make this all make sense to you. With me? So let me see if we can walk through this. Y'all don't just speak out at once. Think about it for just a second. So as somebody's pH is starting to drop, that means they're going to what? It's starting to drop. It's starting to drop. It's starting to drop. It means that they're building up a lot of what?
Hydrogen.
It means they're building up a lot of these. So what would their respirations have to do to get rid of it? So right here, respirations are increasing. Because as they're increasing, are they blowing off their hydrogen? How about that? Now, when it gets a little high, what would respirations need to do to actually be building up hydrogen? What would the respirations need to be doing? Do you get that? So your respirations are speeding up and slowing down just to control your what?
pH.
Which is really controlling what?
Hydrogen.
That's exactly why. Unless you're drowning or suffocating. This is what's controlling. That your respiratory system is the quickest buffering system you have. What's a buffer?
Protective.
A buffer is anything that can help you to maintain pH. And you have an entire organ system that's its major job is to keep you in pH. Is pH important? Balance important? Yeah, it really is. This is why, and I just going to give you this thought before we take a 10-minute break. This is why, and y'all listen to this so you can intuitively make it work for you. Don't you love it when things kind of fall in place? Look, this is why diabetics, diabetes mellitus, diabetics that have problems with sugar and using sugar for aerobic respiration will have to change sugar to fat. And then they'll have to use fat to get to their batteries charged. They have to bring fats into that Krebs cycle, that second part of the aerobic respiration thing. They don't have to use fats. But what did we say happens when you break down fats for energy? You get a byproduct. What do you get? Ketones, which can do what to your pH? Acidosis, dropping your pH. So it's dropping your pH. So when you have diabetes mellitus and it's not being controlled, you have too much of this. So what can have to happen sometimes to a diabetic, especially if they're having a crisis? What happens to their breathing? Have you ever seen them doing it? It's called Kussmaul respiration. It's not a fun sight. What'd you say? That's what that means.
They have the sugars.
Oh, the breath. The breath. That's a whole different topic. But yeah, the breath can actually smell sweet too, or a little bit. So anyway, are you good? Are you good with that? Does that make sense? So why are their respirations having to increase? Because they're trying to blow off what? Makes sense, doesn't it? Doesn't it? Y'all get your little heads around this equation because it can help you reason through when y'all get in med surg and they're asking you about respiratory acidosis and alkalosis and you're thinking, oh my God, you need to know this now before you get to there. Yeah, that's what. I'm sorry, did you ask a question here?
No,
Nicole, that's fine.
Can you do COPD then for me? Because
I'm going to talk about COPD. I'm going to talk, they are not able to.
That's what okay.
And so they end up getting CO2 building up. And it can really be, you hear about COPD as being a pink bumper or a blue bloater.
Yeah.
Yeah, we'll talk about that when we get back. Let's take a 10-minute break. Or we'll talk about it soon after we get back.
Can you leave your drawing out?
Yeah. Nobody else in the world would want to see that drawing. I'm going to pause the recording though. So in case y'all say something bad about me. Sure. Somebody says sure. Hey, you also really understanding with that whole part about pH balance and why your rates are going up and down and how it's affecting the hydrogen concentration and therefore understanding pH is really the most difficult part of this. That's good. Just and I get that you might not get it right this second, but go through it slowly when you have time and see if it doesn't make sense to you, okay? And try to not memorize like the cellular aerobic respiration equation like we did in AP1 and then not really take it on further and understand the CO2 and water, just the waste products. Try to do it for you a moment. Okay? All right, so look, when we look at the organs of respiration and we're looking at this little illustration here of some of the organs of respiration, most of you probably are pretty familiar with most of these organs. And this is why I tell students a lot of times that this whole last part of AP2 ends up becoming the easiest part of A&P, period, because respiratory, urinary, digestive, reproductive, male and female reproductive, I think you have a really good solid background, and so it does become a little bit more familiar. When we're thinking about these organs that make up this organ system, they all need to be functioning, right? So they're obviously we need to understand them and what their functions are, but then also that they need to be functioning. And when we'll just look at just the basics of this, we do understand that we have to be able to breathe out CO2. And we know we breathe out CO2 because the red cells from the system have picked up CO2, and they're bringing it back by way of the right pump, sending the blood to the lungs. They're going to give off CO2 and pick up oxygen, come back to what side of the heart? Left, to be sent to the system to do it again and again and again and again, right? All right. So, but when we look at that, and we know air is being brought in, and CO2 is being taken out with each breath of expiration, right? Inspiration bringing oxygen in. When we think about atmospheric oxygen, what's it made of? How much of atmospheric oxygen atmospheric air is oxygen? Like 21%. Well, roughly 20%. Now it would depend on altitude, right? But sea level, all the way up, it's gonna decrease the higher you go. But let's just say it's about 20%, right? So it's about 20%. And what's the rest of atmospheric air? Nitrogen is the biggest component. Y'all would want to know this. Nitrogen's the biggest component by far. And it's really, you know, it's really only like 1+% other stuff like CO2 and water. Is there water in our atmosphere? Sure, it's why those water molecules get together to form clouds. They get heavy enough that they can rain on us, right? So we get that, and you need to know that basics about what atmospheric air is composed of. So about 79% nitrogen and about 20% oxygen, and that 1% or so is going to be all the rest of the molecules we think about in that. But if we look at these organs of the respiratory system, where is that gas exchange actually happening? Where is the CO2 being given off? Where is the oxygen being picked up? Where? Where in the lungs? The alveoli. So the alveoli in the lungs, which are little microscopic air sacs that have capillary blood vessels swarming them, right? So that's where the gas exchange occurs. So what's all the rest of this for? What's all the rest of this stuff for? If that's where all the gas exchange is occurring, you know, why aren't our alveoli just kind of on our skin and we could be getting rid of all the rest of this stuff? But what is all the rest of this? It's actually to be conducting air, and part of that conduction we're gonna filter, but it's for moving air. All of these rest of these structures are for moving air in and allowing air to move out, right? This doesn't make them less important, but that's what their functions are going to be for. Have y'all ever heard of a URI? What does a URI stand for? And what does that mean? An upper respiratory infection. We've all had upper respiratory infections. What does it mean? Where? No, yeah, they do usually know. I mean, usually respiratory infections aren't so hard to figure out if we can listen. Is that what you say? It's an upper respiratory infection. It's anywhere from the throat up. Okay, so the larynx. What do we call the larynx? You call it a voice box, but the real name is larynx. Have you ever heard of laryngitis? Yeah. A URI, right? You said that you can actually have a pharyngitis. And what was the pharynx? Throat. So you can have pharyngitis. Is that a URI? Sure it is. You can have rhinitis. What is rhinitis? Inflammation of the nasal cavity, right? The nose, rhinitis. What is a big cause of rhinitis? Allergies, and then viruses, right? Cold viruses, allergies, cold viruses, you know. So you can have sinusitis, can't you? And does that block your airway? Why do those itises block your airways a little bit? Because what does itis mean? And what you say is one symptom of it. Swelling. And if something is swelling those tissues, what is it blocking? Air movement. And what are those structures for? Air movement, right? So you can have a URI, which is inflammation, which is going to be an infection from the neck up. Or you can have a lower respiratory infection, and what would that include? What would that entail? The trachea is going to be what people call the windpipe, right? The trachea is rarely what we see as being involved, but it can be. But we often see where the trachea breaks off, where it first breaks off to the right lung and the left lung. These are called the primary bronchi. Where the primary bronchi first break off, they're called the secondary bronchi. And where the secondary break off, that's called the what? Tertiary bronchi. Have you ever heard of bronchitis? Of course you have. Inflammation of the bronchi. And again, the lumen, if the lumen is narrowing because of inflammation, what's having a harder time moving? Air is having a harder time moving. So bronchitis is a lower respiratory tract issue, isn't it? Then you can even, in the lungs at the alveoli, the membrane level, you can have thickening of those membranes where fluid is coming in. Do you know what that's called? Pneumonia. That's called pneumonia, right? And we'll talk about that in a little bit. But so pneumonia and bronchitis. Where these, and you can see these bronchi, there's a bronchus, a singular bronchi, many of them. You can see these still visually, but they're even going to start breaking off into smaller and smaller into areas we call bronchioles. And you have bronchiolitis. You can have bronchiolitis. I know I'm skipping around here. That's better than reading a PowerPoint. How many of you had PowerPoints read to you? Oh my God, isn't that just awful? PowerPoint's losing their power and their point. You guys, look. So this is actually, can you imagine this dissection, how tedious this was? So you can see how tiny these bronchioles are. They're supposed to have certain size lumens, but if you've got bronchiolitis, again, blood is not getting to those alveoli like it should be. Air movement is not getting there, is it? So bronchiolitis, and then again, I told you, even in the microscopic air sacs, the alveoli, you can have thickening of those membranes, which is pneumonia. So those are all lower respiratory tract infections. Which ones are the most dangerous, do you think? Lower ones. We tend to think the lower ones are the most dangerous. We do. We tend to think about the lower ones being the most dangerous. But I want to tell you about one structure here that's important, and it kind of gets overlooked, and it should not get overlooked. And I'm going to need you all to be able to label everything on this picture. So everything would be fair game, plus I'm going to add a couple of things. But there, here it is for you. This is just labeling. When did y'all start learning anatomy? Before you could what? Talk. You've been practicing learning structures, names for a long time. This is not going to be bad. And we're going to talk about all these structures, so it's not going to be bad at all. But I want you to notice this structure, and it's hard to see it from this picture, but we're going to look at it in a second from anterior and even posterior views. This glottis is the opening to the trachea. The larynx is right below it, and this is the trachea, right, what people call a windpipe. Now, there is a cartilaginous, a cartilage flap. Everybody do like this. A cartilage flap that is actually will block this trachea so that when we swallow food and liquid, does it always go down our windpipe? It rarely does. And when it does, is it frightening? It is, but it usually doesn't because of the what? And it's called that because where is it? Above the glottis. It is. And it's a flap that kind of keeps anything but air out of your trachea. Beautiful. We love this cartilaginous flap. All right? It can get inflamed. And that's called epiglottitis. I want to write that down. That's called epiglottitis. Is it an upper respiratory infection or lower? Upper. It's upper, and it's deadly. The mortality rate is really, really high. Why do you think the mortality rate would be so high? Just because it's an upper respiratory infection? Why? Because it really blocks the trachea. Because if it swells, and what does itis mean? It can swell. If it swells, what have you blocked? The airway. And if you don't have somebody that's near you with the trach set up to do a tracheotomy, are you going to be in trouble? How many minutes is it going to take for you to be in trouble? 4 to 6. After 4, you could be having some permanent damage. After 6, you're probably gone. This is why when somebody has a sore throat and they come in and they have a sore throat, now it's usually just viral, allergies usually, or viral. About 3% are bacterial. That's almost never, right? Think of 100 people in a room with a really sore throat. Only about 3 of them have a bacterial reason. But it's why, and that's usually just strep, which I said you're going to get over sooner or later anyway. But on rare occasions, now it's even more rare for good reason because of immunizations. On rare occasions, it can be epiglottitis. This is why you don't take somebody and say, oh, you've got a sore throat, let's just get that throat swab and have the results before you even get seen. I've been part of doing that myself. But before you ever had somebody, you put something in somebody's mouth, including a tongue depressor, you watch them, and if they have put their head back to keep an airway open, and if they're looking anxious, and they're telling you they have a really sore throat, and you're seeing they're not even spitting or swallowing, don't put something in their throat. Because if it is epiglottitis, just any little irritation to that epiglottis can cause it to swell and block the airway. And then you're going to have to be responsible for trying to get them an airway. You look to see, because if the epiglottis is swollen, it will look like a little snake coming out the back of their head. When they say ah for you and open their mouth, you're going to be able to see it. It's going to look like the head of a snake coming out at you. And then you're going to say, okay, call the rescue squad, because you're going to move from my clinic to the ICU by way of the rescue squad, right? Because it's that dangerous. Luckily, we don't have people getting it too much anymore because of the immunization called the HIV vaccine. Does anybody know what the HIV vaccine stands for? What HIV stands for? It stands for Haemophilus. Haemophilus is the genus of this bacterium. No, it's a bacterium. Haemophilus influenzae. That's the species name, serotype B. We all have this microbe in our throats. We all do. But most of the time, it doesn't cause us any trouble. But when it does cause trouble, and it's causing trouble to the epiglottis, it is the cause of epiglottitis, the cause. Now we're seeing less and less people dying from it. And by the way, their death was because of suffocation. It was because of this bacteria causing the epiglottis to be inflamed. But the actual reason they died right then was because they couldn't get air. We're seeing less and less deaths from this because of the vaccine, HIV vaccine, which is part of the pediatric protocol. Right? All right. So, good. That's the good news. The bad news is that it's still out there.
How would you treat it?
So you put them, that's a great question. So you do IV antibiotics. The good news is that it's fairly sensitive to most drugs. You do IV antibiotics and they're in ICU. They're in ICU, and you know, their throat is really, really sore and they're feeling like they can't get air. But what you do is you put them in ICU with the tray set up beside them. I mean, they've got that there. And then as soon as the antibiotics sort of kick in, you'll start to see that epiglottis going down.
Is it like a recurrence? I mean, if it happens once.
Yeah, it could happen again. It could happen again. But you know, if somebody's had it and they know to not mess around. And the people who've had it, like I'm thinking of one person in particular that was in the ICU for a few days with it, was a man who didn't have his spleen. His spleen had been taken out because of a football injury. And he'd almost died on the football field. But they got him to the hospital. He had a splenectomy. You know, he was within minutes of that. So that had been like a college injury that he had. And now he's in his 40s, right? And he comes in with a throat that he said, you know, I've had strep, but this isn't like it. So they describe it as like strep on steroids, you know, like it's the sorest throat that you can imagine, way worse than strep throat. And I've never had strep throat, so I don't, but I know I've looked at, I think thousands probably of strep throats, maybe not thousands, but a lot. And they look bad. They look bad enough, don't they? But this thing is supposedly, epiglottitis is supposed to be so much worse, and it's blocking air. When people have strep throat, they're not usually feeling like they can't get air. But these people are, and their throat is sore.
Is that something that can be passed to other people?
No, not really. No, you don't think of it. No, you don't worry about it. It's usually the immunocompromised or the people who haven't had immunizations. If you don't have a spleen, are you immunocompromised? Mm-hmm. Yeah, and like for this person, do you think he got the immunization? As soon as he got out of the ICU and got well, do you think he got an immunization? Yes. And guess what? He should have gotten it earlier because his actual doc should have known that if you don't have a spleen, are you immunocompromised? So do you have to be very careful to have all of the up-to-date vaccines? Mm-hmm. Yes, you should. So he made it. He was fine. You know, a little scary there in ICU when they just can tell, okay, what is that setup? That's in case we have to treat you. You know, okay, nobody's laughing about it. But anyway, right? All right, so make sure you know the bacterium and know that. So this is the epiglottis, fine? All right, so we know most of the structures are all about just moving air. The actual respiratory is going to be where in the alveoli, right? Where the actual gases are exchanged. Oxygen is going to be loaded up to the red cells, and CO2 is going to be given off into the alveoli, so that when you breathe out, what are you breathing out? Carbon dioxide. Now, there's some carbon dioxide in the air, so some is actually going in, but you're breathing out a whole lot more when you breathe out than you had in there. So this nose, obviously, is it important to breathe through your nose? Y'all, it's really important to breathe through your nose. How many people would say they're not really nose breathers? Yeah. And so there can be a lot of reasons. You can have a deviated septum, or you can have other issues that really prevent you from breathing through your nose. But actually, in the best world, we would have everybody breathing through their nose, because it has a lot of functions. When we talk about the nose, and kind of I want to go back to this, you see we bring air in through the nares, right? So you bring air in through here. You know, no other class do people pick at their nose or make the funny faces, right? Okay, sorry. But you get what I mean. So you're bringing air through. But look what air does as soon as it enters into the nares. It's going to spread out through these conchi. These are going to be these areas that are very, very vascular. And as air moves through here, the blood, when I say vascular, it means there's a lot of blood supply here. So it is blood warm. So it's going to warm the air. And when air warms, what does it do? It expands. So it's going to warm the air, which is going to cause it to start expanding. And that's going to help to open up the what? Eventually, when it gets down there, that's helping to open the alveoli, right? Makes me stand up straighter when I think about breathing. Can that help you breathe? Mm-hmm. Right. So, guys, it warms, but it also humidifies. And humidifying is really important to know, because where gases are exchanged in those alveolar sacs, where the gas exchange is exchanged on the membrane, between the alveolar membrane and the blood capillary membrane. Think about this. Think about this. I want y'all to think about this. This is the alveoli, right? And this is the little alveolar membrane. And then there's a capillary bringing blood. Are y'all with me? So where these two layers are, they're single cell layer thick. There's this interface between them. Does that make sense? So O2 here has to move into the red cell. And what y'all say has to move out? Carbon dioxide. But gases won't exchange between two areas unless there's a fluid interface. Did you just hear that word fluid? So it should be what? Moist. Well, not really wet, but it needs to be moist, and it needs to be just right amount of moisture. This is why when somebody's on oxygen, you know, they have a little cannula. But when they're on oxygen, not the walking around kind, but like for Bessa, it's being humidified, isn't it? Mm-hmm. And that's going to be a really important thing. People who had anybody have CPAPs? Nobody in this room? Oh, good. But there's this water thing that they're doing too to try to keep it so it won't be drying out, right? So when we think about the nose, we know it's doing that. It's cleansing too, because you know the little hairs in your nose and whatnot, and the mucous membranes. Air is not sterile. It doesn't need to be, does it? We're breathing in feces from dust mites. Yes, we are. We're breathing in pollutants. We're breathing in our neighbor's skin cells. We're breathing in smoke. You know, from burning leaves or smoke, whatever. No, so we're breathing, and that's okay. It's okay up to a point because we have the mechanisms to protect it. It's going to be trapped, and the beauty of the nose is that when it's trapping here, because of this 90-degree turn, as mucus traps particles, they end up kind of coagulating, and unless you have a lot of snot going, you don't even notice that this is going down your throat, and you're just swallowing them. You know, so you're swallowing the dust mite feces. That's okay. It's just adding a little bit to everything. So it's all right. But that is like a really ingenious kind of design, if you will. So air is moving in, it's doing all of those things. But we also think about non-breathing functions, and that's detecting odors, so smell. Because if we started to really smell smoke, or we shouldn't smell smoke, we're going to move. We're going to get out, aren't we? Or if we smell food that's all bad, are we going to eat it? No. Or hopefully not. So anyway, and also just being able to smell too is going to help with our appetite, isn't it? Is appetite important? Yes. Is over appetite? I'm so hungry. All right, so anyway, and then we also think about this as being a resonating chamber for our voices. We know when we have colds and stuff, does our voice change? Yeah, so it changes. Do you have any questions? Now look, guys, this slide makes me realize we label everything, don't we? I'm not going to have you label any of this, but I do just have it on here from your book just to let you know about this little philtrum. This little philtrum, and actually how the nose is formed, but especially the philtrum. This is something that they look for on babies, along with the shell, the ear shell function, structure, because babies that have fetal alcohol syndrome are often lacking this, or have a very shallow one. How much alcohol is safe in a pregnancy?
No.
0. That's exactly right. Not even 1 serving. So if you have a physician, I had a woman tell me one time her doc said she should have a half-glass wine every night. And I said, you need a new doc. You need a new doc. Okay. And I had another student not long ago tell me that her doctor told her to keep smoking so her baby's weight would be small, or her baby wouldn't get too big. Now, I don't know if those people were telling me the truth, about the doc, because they may have misunderstood something the physician said. I'm not saying they intentionally lied, but they may have misunderstood what was being said to them. But you all understand that both of those statements were really ridiculous, right? So smoking is a teratogen, and so is alcohol. We know it. But so just knowing that, and then we also know that as the ear shells are forming, and so are the facial things, is about the time that kidneys are forming, and a couple of the other visceral organs. So when they see this, they look at babies' features, because then they can get a little bit of a heads up on maybe doing more studies to see if kidneys are functioning okay. And sometimes they'll even have babies come back at 2 or 3 years old and do more testing and stuff to see if they can get a step up on problems that may occur. Okay, so anyway.
What's the purpose of the little bit of the?
The purpose is really, I've never really thought about what the purpose is, but I think it's really for directing airflow. Oh, do you see what I'm saying? So same thing as the shells of the ear, not just the shells, but the cartilage folds of the ear are actually funneling sound waves into the outer ear.
So we just need to know that.
You don't need to know anything. I was just telling them for FYI. Really, I'm not going to have you label any of this, but we really do label everything, don't we? So this whole nasal cavity, we said, is doing a bunch of stuff by warming, humidifying, cleaning the air, and we know that. Now, I don't know if I missed it somewhere. In case I did, let me just tell you. This inferior, middle, and superior conchi here, these meatuses, they're really vascular. And every 30 minutes or so, one side of this inferior will become engorged with blood. It has erectile tissue. Y'all thought erectile tissue was only in one place, didn't you? But that's not true. It's actually in this inferior area of the nose too. So if you've ever noticed that on any given minute, you can breathe out of one side of your nose better than the other. Have you ever noticed that? Mm-hmm. It's because it alternates, and your autonomic nervous system is controlling that. So it's engorging this erectile tissue, which is bringing more blood, more moisture, right? And more heat, and then the other side will do the next time. And so it's something you don't have to be thinking about that's happening. But because of that, because there is this erectile tissue, this is where when that person does have nosebleeds, this is usually where the nosebleed is happening. So if they have to go in and cauterize, that's where they're going in to look, is in this particular area. Has anybody ever had an examination of the nose where they've taken the lights up? And I haven't either, but I've seen it, and it doesn't look like it would have felt very good. But anyway, that's why. And what is a nosebleed? What's the medical term for nosebleed? Because you're going to be asked that. What's the medical term? Epistaxis, right? That's somewhere in his notes here. But anyway, just make sure you know that's the medical term for nosebleed. Where is it somewhere? Anyway. All right, I don't know. I thought it was somewhere in your notes. So pharyngitis, we said, is actually inflammation of the throat. The pharynx just means throat. You have different regions of the throat. The nasopharynx, which is kind of behind the what? Nose. The oropharynx, which is behind the mouth. And the laryngopharynx region, which is below us, which is kind of behind the voice box area, right? So you can see these are different regions of the pharynx. Y'all know that in the nasopharynx, there's tubes that drain to the nasopharynx. What are those tubes called? Eustachian tubes, right? Or what auditory tubes or eustachian tubes. And what do those eustachian tubes, what are they draining? What area are they draining? The middle ear. The middle ear, which should be filled with air. But because there is this opening, do we understand why sometimes when you have a lot of fluid in your, maybe rhinitis, so it's really the nose, do we understand why our ears feel like they're filled too, right? And we also said that in the nose we have this duct that is going to drain our what? Ears? Yes. And so this is how there's this connection between the eyes and how sometimes microbes can move, sometimes at will, between any of those areas. The middle ear, the nasopharynx, and even the eyes, right? Okay. All right. So anyway, the pharynx. What's the most common cause of sore throat? What'd you say? Oh, you said child abuse. I was like, what? So anyway, so its most common cause is allergies, and then the next most common cause is viruses, and the rarest of all causes is really bacterial. And there's several different types of bacteria that can actually cause pharyngitis, though. Usually their presentations are pretty obvious. Y'all, has anybody in this room seen strep throat? Have y'all seen somebody with strep throat? They have these white exudates but guess what the white stuff is? Pus. It's pus. So it's called pyogenes, streptococcus pyogenes, because it generates pus pockets. It really does. And so you'll see these exudates in the back, they'll be on the tonsils and sometimes even on the wall of the pharynx. It also has a certain smell, strep throat does. So usually, it presents in a particular way. All right, so anyway. So I was going to tell you this about the larynx. We said the larynx is, what do we call it? We call it the voice box. And I really wanted to give you views of this, the front, this anterior, posterior, and then the mid-sagittal, so y'all all see what I'm talking about here. You can see this cartilaginous flap, the epiglottis, can't you? You see that? So anyway, this is the hyoid bone, just to give you perspective here, and the cricoid cartilage, which has a little bump in it. If somebody's doing a trach, do I have any EMT people? I do, Madeline. Have you seen, hey, cool, that's so cool. Are you in it now?
We take our practical exam tonight.
Oh my gosh, okay, you want to get out here so you can go study. That's exciting. We'll be cheering for you. Madeline, have you actually, because I'm sure you have to start this, have you volunteered? So have you had to see any of this? You haven't seen one yet? So, usually, well, I don't know if I want to say usually because I don't know the numbers, but oftentimes this is an emergency procedure. I've seen it done in the ER. But sometimes it's actually emergency procedures in the field.
Advanced EMTs.
Yeah, the paramedics and advanced EMTs can do it in the field. But so it can happen. Now sometimes they just make a decision because they know the airways are being compromised, so they make a decision to put in a trach. But if you're in a hurry, because it's an emergency, you can see that you can mess up on this thing, right? The cricoid cartilage got this little bump in it. So what the people who do these learn how to do is feel for that cricoid cartilage. And they have to go in between. So supposedly they're trying to go right below. Now the thing is, if they go into the cartilage, you can imagine how tough that would end up being, right? That would be like a tough kind of little situation to get into. And they can actually damage it, and sometimes it's permanent. So sometimes the person's going to have to keep that in, right? Do you know anybody that does?
My grandpa and I take care of my person.
You had to take care of the hose, had to keep it drained. Yeah. So anyway, I mean, it's obviously though saving lives because they've got to have air. And so, but there is a little bit of risk to that. And I want you to see that the trachea itself has these C rings. There are these C rings here that if you looked at them from the back, they don't go all the way because, and you wouldn't want them to, because do you know what structure is right behind the trachea going all the way to the stomach? That's a muscular tube that's carrying liquid food and water to the stomach. And that's right behind this trachea. So have you ever swallowed something before you got to chew it enough? And for a split second, what got closed off? Your airway got closed off. And you thought, choked, okay, right? But then it kind of moved on down because this is a muscular tube that's taking food and liquid. But this is designed this way so that food and liquid can kind of push on it a little bit. You know what I'm saying? It shouldn't be big little things because that's too much. But anyway, so it's designed to stay open. When y'all do the dissections of the rats that y'all are going to do in 2 weeks, you're going to dissect rats. I'm going to get you to isolate the trachea and go behind the trachea, and you'll see the esophagus, which is a little flattened muscular tube. It's flat when there's no food or water in it, just a muscular tube. But I'm going to get you to tease that trachea out. And as you tease the trachea out, guess what's attached to it? The lungs and the heart are attached to it, so it's going to all come out as one piece, right? And you're going to see even on the rat, their little cartilage rings are keeping the trachea open. So these C rings do a great job. They keep your trachea open at all times, right? So anyway, I just wanted to show you that picture. Now I want to talk to you a second about a baby's, an infant's larynx. So, and maybe this picture is going to be the best way to look at it. You guys, when we swallow liquid and food, you and I, when we swallow it, we can't breathe while we're swallowing. If you've ever tried to breathe while you're swallowing something, it would not be a good idea. You're going to aspirate, right? And aspirate means you're going to suck it into your trachea. But have you ever wondered how infants, Maya, have you ever wondered how infants, when they're eating, sucking bottles or breastfeeding, they're breathing at the same time? Have you ever wondered? Okay, well, this is the reason why. And your textbook is a little bit misleading on this. It says it's because the epiglottis is immature. It's not. It's supposed to be like this because infants have to have this instinct to be breathing and feeding at the same time. So it's not really immature. It's supposed to be like this. Instead of this epiglottis closing, it will form like a tent. And so what happens is milk will be coming into the esophagus, but air will be coming still into the trachea. You get what I mean? So they can do it both. When you start seeing a child, and it's usually around 12 months of age, usually. Around 12 months of age, now some a little earlier, some are a little bit later, but around 12 months of age, if you've ever seen a child with a bottle that are walking, sometimes you'll see kids with bottles and they'll say, fill it up. That's probably time to stop the bottle when you tell you that. So anyway, but if you see them with a bottle and you see that they are not breathing while they're sucking, time to get rid of the what? The bottle, right? Because they don't need it anymore, right? Hard to realize, but it's really, really true. So anyway, and then after it gets hardened, then you can't do that anymore. You can't breathe and drink and eat at the same time. So that's actually a normal thing for them to do. If we looked at if you had a laryngoscope and you were looking down at this, you can actually make out, even in these pictures in your book, the C rings that are down there. But your larynx is going to have these vocal cords, which are muscles that you're voluntarily controlling as you're moving air through. So this is a non-breathing function, non-respiratory function of air, right? Is to be able to speak and to be able to make sounds. Fair enough? All right, so if you're looking at the actions of some of this, and you don't have to label these, but just looking at the actions. Now we know our tracheal epithelial are cilia. Do you remember this from Anthony 1? And what did we say cilia do? Move things in one direction, don't they? They may look like when you're looking at them that it's kind of willy-nilly, but it's not. It's moving substances in one direction past the cells. So in this case, it's like an up escalator. The goblet cells are secreting a thin layer of mucus because you have saline also being secreted because of the chloride pumps, remember? And the cilia are, the mucus is catching any of the pollutants that got through and you didn't swallow. It's okay because in the trachea they're catching it and they're just moving it up. And that's fine. And as they move it up, usually here, again, it's moving across the esophagus and we're swallowing it. And it's not taking us to cough or do anything else. Now, if you're in a high polluted area, though, what are you having to do? Right? You're having to even help your cilia get that up. Is that true? Yeah. So hopefully that makes sense. Now, we also talked about the idea there's a disease. It's an inherited disease called cystic fibrosis. Cystic fibrosis is the most common inherited disease of lighter toned people. It's the most common inherited disorder, and it's an autosomal recessive disease. So what does that mean? You have to get a trait from both parents, and the trait has to be recessive, right? So can you just get cystic fibrosis from your mom? No. Or just your dad? No. They both had to give you that recessive trait. This is a disease that affects the chloride pumps. So what happens is they're not able to pump out chloride and get this nice saline solution helping to clear. So what happens is the mucus builds up. And as the mucus builds up and it's not able to be moved, what are they at risk of? Infection. What they're most at risk of, the infection they're most at risk of is from a bacterium known as Pseudomonas aeruginosa. This is a bacterium that's everywhere in our environment, especially in our water lines. This is a bacterium that's everywhere, Pseudomonas. It's the one that causes swimmers' ear. You know, it's the one we worry about in burn units because it's just so prevalent. The risk of it, though, is so bad because it actually is really difficult to treat. And when cystic fibrosis patients do, you know, die from lung and respiratory things, it's usually lung and respiratory related. It's usually from this species of Pseudomonas or another one that's known as Cepacia. It's one or the other of these species. So it's tragic, right? We know that cystic fibrosis patients, there's different variants, genetic variants of it, but you know, a lifespan is about at most 30 years old. But many of them, to be able to live that long, might have to have lung transplants.
What is the lung transplant do? Like since it's in the trachea?
Yeah. Well, no, it's not. It's not just in the trachea. It's just that they're not able to clear from that. The lungs become damaged after recurrent infections.
So the
pneumonia.
would it just happen again?
Yes, it will, and they'll have to. If they get 10 years from the transplant, they'll be really happy. They get 10 years, and then they usually have to get another transplant to keep going. So that was the last I heard. For most transplants, you think 15 years is pretty good, but they have a progressive disease. So if they get 10 years from that, they usually consider that to be a successful transplant. I've seen cystic fibrosis patient, I've got to see one wake up from the transplant. And that particular one, this was long ago, so I'm sure they've gotten better at it since then, but that particular cystic fibrosis patient, one of the first things that this person said was, this is what it means to breathe. Like the lung, like he didn't even know what it felt like to get that air in the lungs. He immediately felt better. Can you imagine immediately feeling better after you've woken up from a lung transplant? What do you do?
Do they usually do both lungs?
Yes. Yeah. Actually, I don't know if this is still true too, but thoracic surgeon, this was a while ago, so again, maybe the procedures have gotten better. I'm not up to date on these procedures anymore. I'm not in this field. But I used to work with all the cystic fibrosis patients in Charlotte, so I worked for Robert Selden, who was like, he was really internationally known for for cystic fibrosis as a pioneer in the genetic research for that. But we had people from several states that would come to UVA that would bring their kids that had cystic fibrosis. I forgot what you asked me. What you said?
I just asked if they did both lungs.
Oh, so I had, at that time, a thoracic surgeon, thank you, a thoracic surgeon actually said it's actually easier to do heart and lung, not just lung. And that might still be the case. Has anybody heard that? They said it's an actual, and I guess it's just this, I'm not saying plumbing, but you know what, but all of the electrical and plumbing, it's just easier to do the whole thing than to do whatever. But I don't know if that's still the case. Maybe they do just do the lungs still. So anyway, so now we're just looking at this lower respiratory tract, and you'll see on that slide. I told you need to know the structures. You'll see primary, secondary, and then tertiary bronchi that you need to label. But look here, you're going to need to add this to your diagram. Looks like a notch cut out here. Look, the right lung doesn't have this little cutout, does it? But look at the left lung. The left lung has this cutout, and it's called the cardiac notch, because guess what's sitting there? The heart. But the heart's sitting in a sac. What's the sac called? Pericardium. So we do know the heart's sitting right here, and this is why on the left lung. And if you look at the left lung and the right lung, are they symmetrical? No. The right lung has three kind of distinct lobes. The left lung theoretically has two, right? And so they don't look symmetrical at all, and you have this cutout here. How about the primary bronchi? Do they look symmetrical? They don't. The right bronchi has a much steeper slant, doesn't it? Then this has an acute kind of angle. This is why when somebody's aspirated something and they're in an emergency situation to go down there and get that thing, they're usually going this way. Because where is it usually gone to? The right. And it has usually gone there. So anyway, so you just see the lungs aren't really symmetrical. And the bronchial tree, I just think this is an amazing, you can see why it's called a bronchial tree, right? This either looks like it could have been the root system, or if you turned it upside down, it really truly looks like a what? Yeah. So a beautiful dissection of that. And we understand the bronchioles are tiny little structures moving air. They don't have cartilage at this point. So, you know, they're really, really tiny, and they're eventually going to get to what are called respiratory bronchioles. Are y'all okay for about 5 more minutes? Y'all okay? We're getting through this pretty good, actually. We've done the toughest part. Are y'all okay for a few minutes? All right. So this is what I want to spend a few minutes about, and this is this whole idea about the alveoli, right? And so we've got these terminal, these last bronchioles bringing air to the actual alveoli. And so I want you to be thinking about the alveoli right now. And I think it's just easier from an illustration than a histology slide. These histology slides are human lung tissue that has been stained for you so you can actually see the membranes. But I think it's easier to visualize in a 3D or instead of a slice. Do you get what I'm saying? So I want you to look at this 3D illustration. And I want you to realize that these last little bronchioles are bringing air into these alveolar sacs that are composed of these alveoli, which are almost like, to me, I sort of imagine this as like, you know how bubbles will build up? You got these little bubbles. These are the alveoli in this whole little sac. Air has to move in, and if you notice, for each little alveoli, what is swarmed over it? The blood capillaries. And where is blood coming from? It's coming to the lungs. Where is it coming from? Which side of the heart? The right side of the heart is pumping blood to these alveoli, to these capillaries. And what level does all the exchange occur? Capillary level. And look at this little microscopic alveoli. It's got its own little membrane, 1 cell layer thick. This whole microscopic alveoli is swarmed with little 1 cell microscopic capillaries over it. So blood's coming. Does the blood get to stop and wait to give off the CO2 and oxygen to pick up? Or is it just having to happen quickly? Does it take any energy for that to happen? No. Doesn't take. Now I want you to take a look at just one. If we just took one and we sliced it, Now we're looking at this one. We're looking at one that we sliced, okay? And we got the little blood capillary that's been transversely cut. One cell there. You with me on this illustration? So it's been cut. Let's see this one. So it doesn't get to stop. Blood is moving, but CO2 has to move out and O2 has to move in. And y'all said these two membranes here and a fluid interface between them is going to be important because gases can't move unless you have that between. Is that right? Did you say? So we know, but it needs to be just right. If for some reason this started to thicken, would it take it longer for the gases to exchange? Could that affect oxygen perfusion? Could it? Could it affect oxygenation in the tissues? Yes, because that's going to be affected. And when this is thickening, what do we call that? Pneumonia. We call that pneumonia, didn't we? Now, so we don't really want to see it that way. I want to leave you with another thought and remind me somebody to start right here when we get back. But I want to leave you with another thought, and it's a little ways down, but I think it's just the best place to show it to you. Do you understand? I don't know why I don't just move the slides around because I never do them in this order. So why don't I just change it? All right, okay, don't look at the last two. But do y'all understand if this were a histology slide of somebody's lungs, and by the way, it was, and we have this surface area. Don't pack up yet. Are we ready? Are we ready to hear? So you have the surface area of the alveoli. Do y'all realize, y'all told me you had to have that surface area, that membrane, for oxygen to move in and CO2 to move out. This is a finite amount of space. Like you could actually count. So they say that they've done these studies to say that a normal adult, which they call 150 pounds, which means that the lungs are a certain size, a normal adult, their alveolar space would cover half of a football field. And so with a quiet breath, which is about this much air, and a quiet breath, meaning at rest, not if you're panting, but a quiet breath, every inhale, you have about this much air moving across half of a football field. That's phenomenal, isn't it? Now, I want you to think about that football field. If there's astroturf, that's your alveoli. That's your lung tissue. But it's only one cell layer thick. But right underneath the astroturf is another one cell layer thick membrane of the what? Capillaries. So for every inhale that you had, about this much air moves across a half a football field. Oxygen will move into the red cells, and those capillaries. CO2 will move out, and then when you breathe out, you're going to be carrying this much out. That's amazing, isn't it? Because that sounds like that would take a lot of work. But actually, it doesn't take any work. It's just beautiful in the design because oxygen's going to move in just because of passive diffusion. There's more oxygen on your inhale than you have in the red cells. So it's just passive diffusion. It takes no ATP. Does it take any ATP to get rid of CO2? No, because in your bloodstream, there's a lot of CO2 and not much in the alveoli. So CO2 will unload, oxygen will load, no energy, passive diffusion. That's kind of beautiful, isn't it? Really? So I want you to keep that in mind. But is that a finite amount of space? So what I am talking to you about here is that we need these. We need it looking just like that. We need this. Because if fluid starts thickening the wall, now you might still be bringing in this, but do you have enough time for that diffusion to happen? So are your tissues starting to suffer? Are you becoming hypoxic? Yes. So this is pneumonia. This is an acute illness. Acute means that, you know, it's an acute illness. So anyway, what usually causes pneumonia? What's usually the cause of pneumonia? Viral or bacterial? Mm-hmm. It's viral. If you have a bacterial pneumonia, you're in a hospital, and you probably they might be looking at putting you in ICU. Bacterial pneumonia is deadly. It has a really high mortality rate. Most pneumonias are viral. So why do people get antibiotics if they have viral pneumonia? Why do you get an antibiotic? Suppress the immune system. No, in this case, it's not really to suppress the immune system. What is it? Because if you have a viral pneumonia, are you immunocompromised? Are you at risk for something coming in and getting on top of it? And so what they do, why they give you, and this is the right thing to do, because you know me, my kids say that I'm so against anything. Like they're like, Mom, you wouldn't even treat somebody who died with an apple. That is not true. I'm not against medicine. I'm not at all. I just think it needs to be appropriate, right? And it is appropriate to give an antibiotic for viral pneumonia. It's not helping the viral pneumonia at all, but it's being given prophylactically. That means to protect you from getting a bacterial pneumonia on top of it. Because what do we know about bacterial pneumonias? They're deadly. They're deadly. Well, most of them are. Walking pneumonia is from a bacterial pneumonia, and it's not usually deadly. It has a low mortality rate. But most bacterial pneumonias are really deadly. So that's why. Sometimes meds need to be given prophylactically. Now I need to show you something else. And this is the last thing we'll end on. You ready? And it's important. COPD. What does COPD stand for? Chronic obstructive pulmonary disease. Everybody know that? If you don't, you need to. COPD. What are the two major causes of COPD? The World Health Organization is about to add a third. But what are the two major causes of COPD? Asthma and emphysema. The World Health Organization is about to add a third, and that's obesity. How can obesity obstruct your air? It's in a lot of different ways. But yes, the diaphragm has to be able to move. You know, it's any of us that have had trimesters, 2 weeks overdue trimesters. And I have a long torso, so I never really did get out of breath. But especially people with shorter torsos, is it hard to breathe when you have a third? Yeah. So, you kind of see it can be a little bit hard, and chronically over time, it can damage the lungs. So they're about to add obesity to that third. Now there's a symptom that goes along with all COPD. Do you know what it is? No. But thank you. I know there's a symptom that goes along, and it's bronchitis. Bronchitis. And because you've got this obstructed airway, it can inflame the bronchi. And is that just kind of contributed this? So then that ends up kind of contributing. We understand that bronchitis does not need to be treated with antibiotics. They are not called for. But when people have bronchitis, what are they demanding? Antibiotics, which are causing resistance. And so later, if they do end up getting something, it's going to be more difficult to treat them, right? But bronchitis is usually a side effect of the obstruction disease. Do you get what I mean? All right, now, I want to talk to you about emphysema. Asthma, we know it causes asthma. What is asthma? We just talked about it. What is asthma? Asthma is a type 1 hypersensitivity. It is a reactive airway disease to allergens, isn't it? So somebody has got these things, and it might be normal in their environment. It might be something that's like pollen or dust or something that causes their airways to close. Is every asthmatic event a life-threatening event? Yes. Yes. Guess who's going to die on you the most for asthma attacks? The mild asthmatics. The people who have serious asthma, guess what they always have on them 24/7? Rescue inhalers. But guess what the mild asthmatics have on them? Nothing. And then if they're not near an EMT like you, or they're not near a place, you're talking about minutes. It's the mild asthmatics that will scare you the most in your ERs. I can promise that. So emphysema though. So we know what asthma is. What's emphysema? And what's it caused by? And y'all listen up close to this. 99% are smoking or smokers. So what does that mean about emphysema? It's essentially what? Preventable. About 1% or so are actually inherited disorders where they're lacking an enzyme that's needed to clear the lungs. And those people die of emphysema in their late 20s, early 30s. They never smoked. It was an inherited, horrific, awful thing. I want y'all to know that emphysema, and maybe I've told you, but in case I haven't, is if somebody gets diagnosed with emphysema, it is a progressive terminal diagnosis. What does that mean? It's going to get worse, and it's going to kill them unless they step out in front of the truck first. Let me say it again. Emphysema is a progressive terminal diagnosis. It is mostly preventable. It is also the worst death you will ever witness. If someone really dies from advanced end-stage emphysema, you won't witness a worse death for any patient. The good news about it is that if people can turn their behavior around, they can extend their life. And the other good news about it, so I'm not telling people if they get that diagnosis, they're supposed to give up. They're not. They can greatly extend their life. I personally know someone who was very close to me that extended their life from a year to almost a decade. That's a good extension, right? Not long enough, but it was a good extension. But if they had not, they wouldn't have made it through the year. If they had not changed everything about what they were doing, they wouldn't have made it through the year. Let me tell you the other good news, and still died way too young. But and I've seen people in end-stage emphysema, but it's kind of rare, and that's the good news, because usually they're going to die of a heart attack way earlier than they die of emphysema. Why do they die of a heart attack? Because it absolutely puts such a burden on their heart that their heart will give out first. And dying of a heart attack is going to be a much easier death than suffocating 12 times a day on air like a fish out of water for the last 6 months of your life. And every time they suffocate, they lose body function, they urinate, sometimes defecate, completely pass out, and then come back to and don't want to come back to because they know it's going to happen again in a little while. It's the worst death you will witness. Worse than pediatric oncology, worse than any death, because it's nothing you can do. They're suffocating on air. And it's what? Preventable. It's a legal drug. Guess what drugs are the most abused? Legal drugs. Preventable. And it's because you lose the surface area. Let me tell you what quickly, and then I'm going to let you go. What happens in normal is air moves in, cross that, air moves out. With people with emphysema, because of smoking, air gets trapped in here. And as it's trapped, it breaks the membrane. And as this membrane breaks, the next inhale, it won't be the next one, but soon after, more air is getting trapped and more membranes are what? And instead of having this much perfusion with every breath in and breath out, you have decreased it by half. A pulmonologist, Paul Surratt, was his name at UVA, told me one time, you want to know what an end-stage emphysema is feeling when they're breathing? He said an asthma person in an attack, which is life-threatening, it would be like you as a healthy person breathing through a milk straw. I want you all, the next time y'all think about it, to do this. If you were to close your nose off, don't cheat, and put your lips pursed around a milk straw, like an asthma person in an attack is doing, and do it for 5 minutes, you will be starting to panic. More than panicking. You probably won't do it that long. A person who has end-stage emphysema, take the milk straw out and put a coffee stirrer in. It's outrageous. And it's preventable. People who have emphysema have to learn how to breathe again. All the time that they're awake, it's not about breathing in, though they feel that. They're panicked and they're wanting to breathe in, but you have to get them under control and say, no, you've got to breathe out. So they have to do this pursed lip breathing the rest of their life. They have to practice it anytime they're consciously thinking. They have to breathe in normally, but breathe out twice as long through their pursed lips. If y'all did pursed lip breathing for 5 minutes, you would feel lightheaded and you would feel like you're going to faint. And they have to breathe like that to maintain lung function and live longer. They have to breathe like that every time they think about it. I'm serious about this because it is a horrific death to watch. Good news, They'll die of a heart attack first, usually. Okay, with that thought, who needs a cigarette? That's I'm not trying to be sarcastic, but because it's a heart addiction, isn't it? Is nicotine a heart addiction? My husband smokes. I'm not saying this to be critical of anybody. It's just like, it's kind of horrific that we have a legal. What is the benefit of nicotine? Can y'all tell me that? I mean, tell me the benefit. Is there